Thank you. It's my pleasure to be back here again. So, as Ron said, well, we better prevent it. But I'm going to talk about treating it before. I'll take you back in time a bit to the early 1990s. There's a classic randomized control trial, which is still valid today. It's called Endophthalmitis study, EBS. This is a classic randomized control trial called post-cataract surgery in endophthalmitis. It contains subject more than 400 patients in 24 centers in the US. And the results still valid today. I think this is why I compare between intravitreal tapping and injection, compare with vitrectomy, which one is better, and also compare between using intravenous antibiotics or without. In our cases, in this study, EBS study, we see oral steroids, every case, topical antibiotics and topical steroids. Here's the result of EBS. It's still valid until today. Vitrectomy may be beneficial in a group of patients which have initial visual acuity of light perception only. In this study, EBS found that the patient in this group has 3 times higher of achieving final visual acuity of better than 20/40. However, there are some other risk factor of poor final visual acuity, which is at 9 months, according to EBS. Patients with older age, diabetes, chronic irritation, ring ulcer, or abnormal jaw progression, rheumosis, absent red reflex, or posterior capsule rupture are all at risk of having poor final visual acuity. So, if you have patients with endophthalmitis, but visual acuity is like light perception, or have all these risk factors, they may get benefit from having vitrectomy. But the rest of cases, you may do only intravitreal tapping and injection of antibiotics. That may be enough. The result is not different if you have that patient to have vitrectomy. However, in this study, EBS found further that intravenous antibiotics make no difference. And more than half cases in EBS had a final visual acuity better than 20/40. I'll show you a case which you may or may not apply the EBS study results to. This is a 67-year-old female, provisionally in the left eye. Actually, visual acuity is not too bad, 20/30. Tsunami stagnation revealed pupil sclerosis 2+ in the left eye. Otherwise normal, and she had a diagnosis of well-controlled diabetes and hypertension. I remember very well, in August 6, 2016, I did an uneven routine paperwork classification with intraocular lens in diabetes. This is a lens power monofocal lens, straightforward. We use routine preoperative dilating drops and antibiotics to the eye. This is post-operative day. 20/20 vision the first day. Interpretation is okay. Intracameral injections only mildly. Everything seems to be normal. Here's home medication, still routine medication. And then, well, 3 days later, this is 3 days post-operative day. I remember vividly. I'm driving to attend an important meeting. I just have a call from the patient through the hospital system. And she said, well, that operative eye is getting more red and it's more painful and her vision is quite bad. So that's why I'm driving. So if it's you, you're gonna ask her to rest, or you're gonna attend the meeting, or what you're gonna do, or you want to see her right away. So I decide right away that I gotta see this patient. I have to cancel the meeting. And I drive to the hospital and call the patient to come to the hospital right away and see the patient. And this is what I've seen. Visual acuity is hand motion. And well, that's my drawing. It's pretty bad. But the patient's condition is quite bad as well. Hand motion and have a bit of hypopia over there. Conjunctival injection. And there's no view of vitreous. This is only 3 days, right? She had like 20/20 vision 2 days before this. So what you're gonna do for this case? You're gonna Well, I think this is definitely infectious bacterial endophthalmitis. Very early presentation, like 3 days after surgery. Well, I think we have two choices here. Intravitreal antibiotic injection, tapping injection, like in EBS, or you want to do vitrectomy with antibiotic injection as well. You want to put her on vitrectomy or injections?
No, vitrectomy.
You want to do vitrectomy? What's your reason?
My reason for a few things. First of all, it was very aggressive in 3 days, this whole deterioration very fast. The second thing that she is diabetic, although she is controlled, but diabetic put her on more risk. And third thing, because this is the new trend now that they do vitrectomy more earlier than light perception for most of the vet right now.
Okay, that's good. That's good rationale. Somebody wants to do the tapping and only injection, not vitrectomy? It's okay. So, yeah, what I do is vitrectomy as well. I do vitrectomy with antibiotic injection to operative. And here's I call it a series of unfortunate events for this patient. Well, third postoperative day, we have definitely sign of endophthalmitis, and I perform the sutureless vitrectomy, and I try to clean vitreous, and also the anterior chamber fibrin, try to clean as much as possible. I think, well, you're not a retinal specialist, but if you're a retinal specialist, if you do vitrectomy for endophthalmitis, what you want to do is to clean the anterior chamber as well. I think that's very important point that you may gain vision for patients sooner, faster, than just leave the anterior chamber fibrin alone. And well, luckily during the operation, I can see the fundus quite clearly after we remove all the vitreous. And I can see the fibrin along the vessels. But anyway, although you can clean the vitreous quite clearly during the surgery, the next day, everything's going to be like cloudy back again. So in the morning, next day, the visual acuity come back to, well, it's getting better to figure counting, and the hypopia is still there, but it's getting smaller. The 5th day, we start oral steroid, visual acuity is still hand motion. And the 6th day, there's no hypopia, it's getting a little bit better. Visual acuity is still causing picture. And the 7th postoperative day, well, the hypopia is gone, but well, this is my case. So, well, I like her to get better faster. So I put her to have another shot of intravitreal antibiotics. Not vitrectomy this time, just injection. And then the culture results came, luckily. So, well, it's culture positive for Staphylococcus epidermidis, and it's sensitive to vancomycin that we give to her. So things pretty good for us now. So the 10th postoperative day, the anterior chamber finding is getting better. And I can see fundus detail from examination, which is better. And acuity is getting better to be like pinhole 2070. So this is 10 days after surgery. So it's not too bad, right? And the patient is very happy. Well, this is 10 days already, but she's happy that she are able to read the chart again. And then the findings is slowly getting better. So after 3 weeks, postoperatively, visual acuity is getting better to be 20/40, and we can discharge her from the hospital after that. So it turned to be like a series of fortunate events, not unfortunate events, because 2 years after the event, she accepted to have cataract surgery in the right eye. So it means if the patient accepts to have cataract surgery in the other eye, after all those events in the other eye, it means that she accepts already. However, the left eye is still 20/20 vision. This is after endophthalmitis. So I think the story tells me that if you have timely recognition and timely intervention, I think you can get like 20/20 vision for these patients with endophthalmitis. You can have it. You can have it for sure. Okay. So that's part of treatment. I think, well, treatment is one of the things, but as Mark said, we better look forward to preventing endophthalmitis from occurring. That's more important. Back in the 1990s, we look forward to, treating endophthalmitis, but recently we look forward to preventing endophthalmitis. However, I think if you do like postoperative convenient iodine, highly speculum, meticulous sterile preparation and procedures. All these procedures are effective enough for limiting the incidence of post-cataract surgery endophthalmitis anyway. Just doing all this is very important. I think this is essential. If you want to prevent endophthalmitis, the sterile techniques is one of the first thing that you need to do. However, recently, we are trying to find a way to prevent endophthalmitis better. Here is the question that we frequently ask recently. Are intracameral antibiotics necessary? And there's only one randomized control trial from the ESCRS back in 2007, showed that intracameral cefuroxime decreased endophthalmitis rate to be like 0.07% compared to 0.34% in control group. However, if you take a look at the percentage in control group in this study, it's quite higher than usual, right? Because as usual, endophthalmitis rate should be around 0.1%, but in this study it's 0.34%. However, the rate of endophthalmitis when you give intracameral cefuroxime is only 0.07%, which is lower than the common rate that we know. In fact, you can give the intracameral antibiotics two ways. This is the first way. You may mix antibiotics into the irrigating infusion bottle, like vancomycin and the gentamicin that I showed on the slide. However, there's a study showing that there's no necessary time to kill susceptible bacteria for vancomycin if you mix into the irrigating solution. So there's the second option of intracameral antibiotics. Just do a bolus injection. The bolus injection you can do with either vancomycin or oxyfloxacin. The problem is if you do with the vancomycin, you need to compound it. You need to bring the medicine and compound. So doing compounding vancomycin, you may have dilution errors, you may have contamination, and of course you may create antibiotic-resistant bacteria. Although you use oxyfloxacin, this is maybe better than vancomycin because you can use the eye drop, oxyfloxacin eye drop, and you just do it in sterile technique and give the patient as a bolus injection intracameral after a cataract surgery. Well, it's better because you don't have to compound it. You just draw on the eye drop. However, you still could maybe have a chance of increased bacterial resistant antibiotic as well. So we have another choice of we may use the cefuroxime as in the ESCRS. This is a publication back in 2007, as I mentioned earlier. This is a level 1 evidence. However, cefuroxime is a second generation of beta-lactam, right? So it has limited efficacy on gram-negative bacteria, and it has poor efficacy against medicine-resistant staph epidermidis and staph aureus as well. And cefuroxime still contains adverse events like toxic reaction, anaphylaxis, or increased bacterial resistance as well. The better thing for cefuroxime is that, well, it's available in like a pre-packaged injection. It comes in a syringe. This is in Europe, and the study from PSI is from Europe. So in European surgeons, they tend to use intracameral cefuroxime with the pre-packaged cefuroxime. However, surgeons in the US, they don't. I don't think they prefer using intracameral antibiotics after cataract surgery. So the issue of intracameral antibiotics after cataract surgery is still controversial.
Can I ask you a question?
Yes.
With that paper that shows that there's a 5-time lower risk of endophthalmitis, medico-legally, what if the patient gets endophthalmitis and says, "Doctor, you didn't give me intracameral antibiotics"? Do you think you would be liable? Because I don't use intracameral antibiotics, but I worry a bit because of that paper.
And actually the paper has many limitations in terms of randomization, because as I mentioned earlier, the result of the paper indicate that in control patients, they have higher rate of endophthalmitis than general population. So it's still controversial. So although, well, the patient that I showed to you earlier, I didn't do intracameral injection as well. And I just talked to Eddie this morning that in my hospital, in Thailand's hospital at the moment, we have a third-party organization come for like audit our service. We call it hospital accreditation. And when they come to our department, they're going to look for the rate of endophthalmitis. And in my department, the rate of endophthalmitis is like 0.15. It's slightly higher than 0.1%, which is normally accepted. So, well, it's a consensus in my department that from now on, we're going to use intracameral injections to all cases.
Is this true throughout Thailand?
No, it's just in my department. Just my department. So we just...
What do you think in other countries? You don't use this?
Yeah, so, well, what I'm going to say is that, well, the first thing, if you have your endophthalmitis rate higher than usual, you should orientate the resident, right, or the staff in your department. The first step is just you may do the sterile technique strictly. Just talk to all the surgeons that have this problem. Number one is to do the thing which doesn't cost anything. Improve your sterile technique for surgery. That's one of the things. To do the intracameral injection to all cases, I think, well, it's like you solve the problem like in easy way, but you may cause like antibiotic resistant bacteria in the future, and maybe more costly. And well, if we forget to do intracameral antibiotics for 1 or 2 patients, and that patient get endophthalmitis, you may get sued in the future, I don't know. So there's still pros and cons of using intracameral antibiotics. It's not universal. Yeah. So, well, actually, let's come to my conclusion slide. The EBS is still the relevant evidence on treatment of bacterial endophthalmitis after cataract surgery. And the EBS results should be still valid today with less invasive vitrectomy. Nowadays we use sutureless vitrectomy, but in the era of EBS study, they used the 20 gauge suture vitrectomy, but they got the result like half of their patients got visual acuity, final visual acuity more than 20/40. It should be better for today's era of vitrectomy. However, the EBS didn't tell us if vitrectomy can speed up the recovery. Just like my patient, she get better, after 10 days. So we don't know if we just keep tapping the patient, how long it's going to take for a patient to get better, to be able to see the chart. And well, I think we may need another randomized control trial to see whether or not if early sutureless vitrectomy may give better final visual acuity than only with just tapping and injection. Intracameral antibiotics is increasingly used as routine prophylaxis. Although more evidence is needed, as Don said, we need more evidence before general deployment of this policy. And for the young cataract surgeons, I think you will definitely face endophthalmitis, at least 1 or 2 cases in your career, definitely.
And you remember exactly where you were when you got the news, right?
Yeah, as I told you, well, it's when I was driving when I got the news. So how many of you already have endophthalmitis? Yes? How many of you?
All dogs have.
So it means you didn't have cataract surgery for more than 1,000 cases yet. Not yet. So be prepared. And well, early detection and immediate intervention are essential. And keep in mind that final acuity, although patients have endophthalmitis, if you treat them properly, they can have 20/20 vision. They can have it. Believe me, just keep in mind that even though you got endophthalmitis, you should be able to treat your patients to get 20/20 despite having endophthalmitis. That's your goal.
Thank you very much.